Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine educator. So in this session, I'll be discussing the quick discussion on the INICET recall General Medicine questions. So I'll try to make out in a way why other options are not the answers, and I will tell you what exactly the answer is. Okay, so let us start going with this. So there were nearly around 25 to 30 questions asked in the general medicine. So almost all the systems are being covered, like they have covered in detail about the cardiology questions. There were almost 2 to 3 ECGs, and they have covered the respiratory system. Mainly the questions were in the topic of like pneumonia and pulmonary function test. Every time it is a very stock question. And in the endocrinology, they have asked from the adrenal gland disorders, and they have covered almost all the systems. In the hematology also, they have asked like some of the autosomal dominant disorders. So they have covered almost all the topics of the general medicine in around 30 questions or 25 to 30 questions which were asked in the INICET. So let us start with this now. So the first question was about the ABG. So the question is, what will be the diagnosis in a 6 COPD patient with the pH 7.3, partial pressure of the carbon dioxide is 80 and the bicarbonate is 28 milliequivalents per liter. Okay, so if you see the question here, the pH, it is 7.3. That means it is reduced. And then if you take PCO2, it is 80, which is increased. And then you take the bicarbonate is 28, which is also increased. So when pH and as well as PCO2, both of them are in the opposite direction. When both of them are in the opposite direction, what will be the primary acid-base disorder? The primary acid-base disorder will be respiratory. So it is respiratory, right? What happened to carbon dioxide? It is increased. So it is primary respiratory acidosis. So when carbon dioxide increases, your bicarbonate also should increase. So is the bicarbonate increased? Yes, the bicarbonate is also increased. But even though the bicarbonate is increased, the pH is not normalized. So this we call it as primary respiratory acidosis with metabolic alkalosis. Right? Metabolic alkalosis. So among the options which has been given to you, like the first two options, you have respiratory acidosis. So respiratory acidosis due to hyperventilation, respiratory acidosis due to hypoventilation. So you have to understand that when will the carbon dioxide buildup occurs in our body? The carbon dioxide buildup occurs in our body whenever there is hypoventilation with inadequate compensation, because the bicarbonate is increased. Even though the bicarbonate is increased, it is not increased to such an extent where the pH is normalized. If the pH is normalized because of increase in your bicarbonate, then we call it as the adequate compensation. But here the bicarbonate is increased but the pH has not normalized. So that is the reason why it is inadequate compensation. So the answer to this question is the second option. Alright, now moving on to the second question. A young patient developed hyperpigmentation of the distal fingers after being hospitalization like post adrenalectomy. So he was posted for adrenalectomy. After adrenalectomy, like there was hyperpigmentation of the distal fingers. What could be the possible cause in this question? The options are the Addison's, 𝐒𝐻𝐿's, Nelson's and Cushing's. Okay, first of all, let me tell you, in Addison's, you will have the hyperpigmentation. Even in Nelson's, you have the hyperpigmentation. Even in Cushing's, also you have hyperpigmentation. But in Addison's, what is the reason for the hyperpigmentation? Because in patients with Addison's, there will be increase in the ACTH levels. Right? There will be increase in the ACTH levels. So as and when there is increase in ACTH levels, parallelly there will be also increase in the levels of the MSH. Parallelly, there will be also increase in the levels of the MSH. So as the MSH level increases, that will lead to the hyperpigmentation. But in Addison's, the hyperpigmentation what we are seeing is not after the post adrenalectomy. No, right? Even before adrenalectomy also, in Addison's, you have this hyperpigmentation. All right. Now you take in Nelson's. The answer to this question is the Nelson's syndrome. So what exactly is the Nelson's? Nelson syndrome, it is the disorder which occurs after bilateral adrenalectomy. Right? It is the disorder which occurs after bilateral adrenalectomy. And this bilateral adrenalectomy might have done for the Cushing's syndrome. In case of Cushing's, for example, if it is bilateral adenoma, bilateral adrenal adenoma or bilateral adrenal hyperplasia, the treatment of choice for Cushing's is surgical resection. So once you have done surgical resection, in case of your Cushing's bilateral adrenalectomy, if you would have done, then what happens is there will be decrease in the cortisol levels. So once there is decrease in cortisol levels, there will be increase in the ACTH. Right? So as and when there is increase in the ACTH, there will be also increase in the melanocyte stimulating hormone. So as and when there is increase in the melanocyte stimulating hormone, this will result in the hyperpigmentation. Right? This will result in hyperpigmentation. Next, now you take in, and Nelson syndrome is the disorder which is occurring after adrenalectomy. So that is the reason why the answer is Nelson syndrome. Whereas you take in case of Cushing's syndrome. In Cushing's syndrome also you have the hyperpigmentation. Actually Cushing's, we classify it into ACTH dependent and ACTH independent type of Cushing's. So in which type of Cushing's you have the hyperpigmentation is in patients with the ACTH dependent type of Cushing's. Right? So in case of ACTH dependent type of Cushing's, there is increase in the MSH level and that will result in the hyperpigmentation. Alright. So in Cushing's, in Addison's, Nelson's, in three of them you will have hyperpigmentation, but the one which will occur after adrenalectomy, that will be in case of Nelson syndrome. So the answer to this question is C. Now, moving on to the next question. So we have a 14-year-old boy, right, brought by his father, who noticed him having agonal respiration at 5 a.m. in the morning. He was rushed to the emergency department where ECG was performed that showed code pattern of ST segment elevation in V3 and as well as even in V2. So in V2 and V3 there is code ST segment elevation. Which of the following is the clinical diagnosis of this patient? The options are the early repolarization variant, Brugada syndrome, hypertrophic cardiomyopathy, and then the atrial fibrillation. Okay, so first of all, let me tell you in which conditions you have ST segment elevation among the options which has been given to you. So among the options which has been given, you will have ST segment elevation in case of early repolarization syndrome and as well as Brugada syndrome. And in case of hypertrophic cardiomyopathy and as well as in atrial fibrillation, ST segment elevation will not be there. So your option C and D is completely ruled out. Now, in which conditions you have code pattern of ST segment elevation in V2, V3? That is in case of the Brugada syndrome. See, in case of Brugada syndrome, it is not just only the ST segment elevation in V2 and as well as V3. In case of Brugada syndrome, you have ST segment elevation from V1 to V3. In all these three leads, you have code ST segment elevation. Whereas you take in case of benign early repolarization. In benign early repolarization, also you have ST segment elevation, but the pattern is not code, it is upward sloping. I'll show you both the ECGs. Now, this is the ECG of the Brugada syndrome, where you can observe this is what is nothing but your code ST segment elevation. And this Brugada syndrome, let me tell you, it is a sodium channelopathy and it is due to gene mutation, that is SCN5A gene mutation. So this particular SCN5A gene mutation, that is highly arrhythmogenic. If this particular gene mutation is there, this is highly arrhythmogenic. These patients, they are at increased risk of the sudden cardiac death. So that is the reason why the treatment of choice in these patients will be implantable. Right, the treatment of choice in these patients will be implantable cardioverter defibrillator. So that is what is your Brugada syndrome. Whereas you take in case of the benign early repolarization syndrome. In case of benign early repolarization syndrome also, you have ST segment elevation, but it is upward sloping and concave upwards. And this early repolarization syndrome, this is a benign variant. Right, this is benign variant, and these patients, they don't require any treatment. Okay, and they don't have dynamic changes, because one of the very important differential diagnosis for early repolarization syndrome will be ST segment elevation MI, mainly in the anterior leads. And in patients with early repolarization syndrome, you have this ST segment elevation in V1 to V4. And this will be very important differential diagnosis for your anterior wall MI. Then how will you differentiate early repolarization syndrome from anterior wall MI is that in patients with the early repolarization syndrome, you don't have dynamic changes. That means as the time passes, there is no change in the ECG. That is one point. Second point is in early repolarization syndrome, you don't have the reciprocal changes. Actually, in patients with the anterior wall MI, where V1 to V4 is showing ST segment elevation, the reciprocal changes will be in the form of ST segment depression in the inferior wall. So in the inferior wall, you have ST segment depression in 2-3 AVF in case of anterior wall MI. That reciprocal changes will not be there in patients with the early repolarization syndrome. Then another option which was given in our question was about the hypertrophic cardiomyopathy. In case of hypertrophic cardiomyopathy, see, this is the ECG of the hypertrophic obstructive cardiomyopathy, right? That is the HOCM. So in patients with hypertrophic obstructive cardiomyopathy, you have dagger shaped Q waves. Right, you have dagger shaped Q waves, and these dagger shaped Q waves, right, you can observe here, this is what is a dagger shaped Q wave. They are mainly in the lateral leads, that is in V5 and as well as V6 you have dagger shaped Q waves. Then followed by that, you may also have dagger shaped Q waves even in the inferior leads as well, that is in 2-3 AVF you have dagger shaped Q waves. Okay, so this is what is the HOCM changes. And one more important change in HOCM is in patients with HOCM, you have a dominant R wave in V1. Normally you don't have a R wave in V1, but in patients with HOCM you have a dominant R wave in V1. And then followed by that, in patients with HOCM you have strain pattern, that is asymmetrical T wave inversion can be there. Okay, so this is about the ECG changes in patients with the HOCM. So going back to our question, so in patients with the Brugada syndrome, you have coved ST segment elevation in your V2 and as well as V3, whereas in hypertrophic cardiomyopathy you don't have ST segment elevation. And in atrial fibrillation, what will be the characteristic ECG finding in patients with the atrial fibrillation is the rhythm. These patients, they will have irregular rhythm. Right, these patients, they'll have irregular rhythm. That is a characteristic ECG changes in patients with the atrial fibrillation. And another important point is in patients with the atrial fibrillation, there is no P wave. Right, there is no P wave. So instead of P wave, what you have is the presence of the fibrillatory waves. Right, the presence of the fibrillatory waves. So the answer in this question is your Brugada syndrome. All right, so that is about this question. We'll move on to the next one, that is, right, comment on the diagnosis from the ECG shown below. First degree heart block, second degree infranodal heart block, third degree heart block, and then AV dissociation. Okay, first of all, let me tell you where will be the site of block in various AV nodal blocks. You take in case of the first degree AV block. In first degree AV block, the site of block is in the internodal fibers, right? And these internodal fibers are those which will connect the SA node and as well as the AV node. So in the internodal fibers, you have the block in case of first degree AV block. And the second degree AV block, we have two types, Mobitz type 1 and as well as Mobitz type 2. So in case of the Mobitz type 1, the block will be within the AV node, and that too it will be reversible AV nodal block. Right, it will be reversible AV nodal block. That is in case of your Mobitz type 1. And you take in case of the Mobitz type 2, right? In Mobitz type 2, second degree AV block, you have second degree infranodal heart block. All right, then in case of the third degree heart block or in case of the AV dissociation, the block will be within the AV node. Okay, and this block within the AV node, it is irreversible AV nodal block, or occasionally it can be even reversible AV nodal block as well. So the third degree heart block, it is irreversible, and occasionally it can be your reversible as well. Okay, so this is about where exactly is the site of block in various types of the AV nodal block. Now what is given in this, let us just check here. Okay, so if you observe here, you are having a P wave, but there is no QRS complex. And again, this is a P wave. I'm just showing the arrows only for the P wave, and this is a P wave, and this is again the P wave. So here you have a P wave, but you don't have the QRS complex. So here this is again another P wave. So subsequently here also you can observe. So this is the P wave and this is the P wave, and here actually the P wave is getting merged with the QRS complex, and you don't have the the P wave is getting merged with the previous QRS complex, and subsequent QRS complex is not there. So, and what about the PR interval? So if you take the PR interval in all the complexes, the PR interval is constant. Right, the PR interval is constant. So the PR interval is constant, but intermittent drop is there within the QRS complex. So what is that suggestive of? That is suggestive of Mobitz type 2 AV block. So Mobitz type 2 AV block, what will be that? It's a second degree infranodal heart block. So the answer in this question is B. Whereas you take in case of first degree heart block, you just have only prolonged PR interval. That's all. In case of Mobitz type 1, you have progressive prolongation of the PR interval, followed by that there will be drop in the QRS complex. That is what is your Mobitz type 1. Then in case of the third degree heart block, it's a complete AV nodal block. So there is complete dissociation between atrial and as well as the ventricular contractures. Atria will contract on its own and ventricle will contract on its own. That is what is nothing but your third degree AV block. Okay, right. So the answer in this question is B. Right. We'll move on to the next question. Okay, so which of the following anti-diabetic drug is recently approved to be used in patients with the heart failure with low ejection fraction and reduced urine output? The options are linagliptin, empagliflozin, pioglitazone, and degludec. Now, so in patients with low ejection fraction, first of all, you should know what are the drugs. I'm very sorry. So with heart failure with low ejection fraction and reduced cardiac output, not urine output. Okay, reduced cardiac output. I'm sorry. Right. So now you have to remember that what are the drugs which are approved to reduce the mortality in patients with the heart failure? The drugs which are used to reduce the mortality in patients with heart failure are, number one, we have ACE inhibitors or angiotensin receptor blockers, either of these. And the second one is the beta blockers. Right, the second one is the beta blockers. Then followed by that, we have the aldosterone antagonists. Right, then we have the aldosterone antagonists. Right, so these are the drugs which are approved for reducing the mortality in patients with the heart failure, and they improve the outcome of the patient as well. Now to this particular armamentarium, which was there previously, to reduce the mortality in patients with the heart failure, recently the drugs which have been added is the SGLT2 inhibitors. Right, and what are the examples of your SGLT2 inhibitors? That includes empagliflozin, canagliflozin, and dapagliflozin. So the answer in this question is the empagliflozin. Right, the answer in this question is empagliflozin. All right, so empagliflozin is one of your SGLT2 inhibitors. Now otherwise, in patients with the low ejection fraction, what exactly is the drug of choice which will improve the ejection fraction of the patient? So it is your ARNI, that is angiotensin receptor blocker plus neprilysin inhibitor. So angiotensin receptor blocker, it is valsartan. Right, then what is your neprilysin inhibitor? Neprilysin inhibitor, this will be sacubitril. Right, this will be sacubitril. Okay, so this is what is the drug which has been approved for low ejection fraction. Now we'll move on to the next question. Now, which of the following is not a component of the metabolic syndrome? The options are high HDL, fasting glucose levels, waist circumference, and as well as the blood pressure. So in case of metabolic components, what are the components of the metabolic syndrome? Number one, FBS, and that should be how much? More than 100 milligrams per deciliter. And metabolic syndrome, this is also called as syndrome X, right? And these individuals, they are at increased risk levels of insulin resistance. And next important component is the blood pressure. And how much should be the blood pressure? That is more than 130 systolic by 85 millimeters of mercury diastolic blood pressure. That is the second component of metabolic syndrome. Third component is the triglycerides. And the triglycerides, it should be more than 150 milligrams per deciliter. And next is the HDL. So it is your low HDL which is the component of the metabolic syndrome. It is not the high HDL. And how much should be that HDL? Less than 40 milligrams per deciliter. And HDL is considered as the good cholesterol. Okay, so less than 40 milligrams per deciliter in men, and then less than 50 milligrams per deciliter in females. So this is one of the component of your metabolic syndrome. And next is the waist circumference. So if you see the waist circumference in males, how much it should be to consider the metabolic syndrome is, it should be more than or equal to 102 centimeters, right? Whereas in females, it will be more than or equal to 88 centimeters, right? More than or equal to 88 centimeters. So this is about the waist circumference. Then the one which is not the component of the metabolic syndrome is the high HDL. So high HDL is not the component. Actually, what we expect in a normal individual is the high HDL, good amount of HDL. But in metabolic syndrome, the HDL levels are low. So this is about the metabolic syndrome. All right, we'll move on to the next question. Patient was taking ampicillin for upper respiratory tract infection. Then he has started having watery diarrhea for past 3 days. Drug of choice to manage this condition. So now it is ampicillin for URTA which was started. The patient is having the diarrhea. So what is this? This is pseudomembranous colitis. And this pseudomembranous colitis, right, which is secondary to Clostridium difficile infection, right? So what is the drug of choice? The drug of choice is your fidaxomicin, right? Fidaxomicin, that is the drug of choice for pseudomembranous colitis, which is occurring secondary to your beta-lactam induced diarrhea. If the patient is not tolerating the fidaxomicin, then the alternative drug will be your metronidazole. So the answer in this question is B, that is fidaxomicin. All right, we'll move on to the next question. Now, 60-year-old diabetic male presented with the central chest pain. There is also shortness of breath and palpitations, and he presented to the emergency department. ECG was taken which showed non-ST elevation MI. What is the best treatment in patients with the non-ST elevation MI, right? Okay. Now the options are aspirin plus clopidogrel, aspirin plus vitamin K antagonist. Third option, aspirin plus clopidogrel plus low molecular weight heparin. Fourth option, aspirin plus low molecular weight heparin. Okay. Now you take this 𝗫𝐶TE. 𝗫𝐶TE, it comes under what is called as the acute coronary syndrome. Now, what are the components of the acute coronary syndrome? We have 3 components of the acute coronary syndrome. That includes, number 1, unstable angina, then non-ST elevation MI, then we have ST elevation MI. So these are the 3 components of the acute coronary syndrome. So in these first 2, how will you differentiate unstable angina from 𝗫𝐶TE? In both of them, the ECG changes will be more or less same. There can be ST segment depression and T wave will be inverted. But in patients with the unstable angina, the cardiac biomarkers, they are negative, and in 𝗫𝐶TE, the cardiac biomarkers will be positive. Okay, but in both of them, the treatment is same. What is the treatment? Either you take in 𝗫𝐶TE or in unstable angina, thrombolysis is not indication. Okay, we don't do thrombolysis in case of unstable angina or in case of the non-ST elevation MI. What is the treatment that we start in these patients is, we start with the aspirin plus clopidogrel plus statin, right? And to this particular combination, actually these are given as bolus doses, okay? And subsequent management, what is that we add to this is, we add low molecular weight heparin, right? We add low molecular weight heparin. But for ST elevation MI, the options of the treatment that we have is thrombolysis. Then second important option is the percutaneous coronary intervention. Then followed by that CABG, coronary artery bypass graft. Okay, now we'll go back to the question again. So ECG was taken which showed 𝗠𝐶𝐬. What is the best treatment? So the answer in this question will be aspirin plus clopidogrel and as well as the low molecular weight heparin. So in patients with acute coronary syndrome, we always give DAPT. That is, what do you mean by the word DAPT? Dual antiplatelet therapy. Either you take unstable angina or 𝗠𝐶𝐬, or in case of STEMI, after your thrombolysis or PCI, we start with the dual antiplatelet therapy. And this dual antiplatelet therapy should be continued for almost 1 year. And after 1 year, we just give only the single antiplatelet. Okay. Along with this, statin also has to be given. Because the statin is not there in the options, that is fine. But otherwise, if statin is there, we also can add statin to this particular combination. Okay. So the answer in this question is C. Now, we'll move on to the next question. Most common cause of the hypercalcemia in a hospitalized patient is, the options are malignancy, parathyroid adenoma, parathyroid hyperplasia, then hypervitaminosis D. So most common cause of hypercalcemia in hospitalized patients, it is malignancy. Otherwise, like you take parathyroid adenoma and parathyroid hyperplasia. This parathyroid adenoma, this is the most common cause of primary hyperparathyroidism, right? Most common cause of primary hyperparathyroidism, that will be solitary parathyroid adenoma. But the question asked here is not the question about what is the most common cause of primary hyperparathyroidism. The question asked is, what is the most common cause of hypercalcemia in hospitalized patients? That will be your malignancy. Now, what are the malignancies that can contribute to the development of your hypercalcemia? So that will be your squamous cell carcinoma of the lung. So squamous cell carcinoma, right, squamous cell carcinoma of the lung, it will release the parathormone-like protein, or it will release the parathormone, and this parathormone will increase the levels of the calcium. And one more malignancy which can produce parathormone-related protein will be your pheochromocytoma. So in patients with the pheochromocytoma, there will be release of parathormone-like protein. So this parathormone-like protein, right? So they are the one which will increase the calcium levels, right? They are the one which will increase the calcium levels. So the answer to this question is the malignancy. All right. Now we'll move on to the next question. Okay. So which of the following will be used for diagnosis of the infective endocarditis? So basically the question which has been given is on the blood cultures, the number of blood cultures that has to be collected and where it has to be collected from. So first option, 2 sets of blood samples from the peripheral vein 1 hour apart. So 2 sets of the blood samples from peripheral vein plus 1 from affected heart valve, both 30 minutes apart. 3 sets of blood samples, 2 from peripheral sites, 1 from the central vein, both 30 minutes apart. Fourth option, 2 sets of blood sample from the peripheral side and 1 from the tip of the central vein 1 hour apart. Okay, so the answer in this question is D. Now let me try to explain to you this. So in case of the infective endocarditis, the criteria that we use is Duke's criteria or the modified Duke's criteria. So according to this modified Duke's criteria, you have 2 major and as well as 5 minor criteria. In the 2 major, one of the major criteria is the evidence of endocardial involvement. The evidence of endocardial involvement that can be made out by your 2D echo, right? And second important major criteria is blood cultures. And in the blood cultures, you need to collect 3 blood cultures. Okay, so these 3 blood cultures should be from 3 different sites, right? And how much should be the time gap between the 2 samples, right? Minimum time gap should be 1 hour apart. It should be 1 hour apart. So you take your 30 minutes apart. So these options are completely ruled out. Okay, and you take the first option, that is 2 sets of the blood samples. Even that is also completely ruled out. It should be definitely 1 hour apart between the 2 samples. And you take the fourth option, 2 blood samples from the peripheral side and one from the tip of the central line, 1 hour apart. That is correct, because actually the textbook says that 3 blood samples from 3 different sites. 3 blood samples from 3 different sites. That is what the textbook says. And 3 different venipunctures. But here what has been added is one from the tip of the central vein. Even that is also correct. So 2 sets of blood samples from the peripheral sites and one from the tip of the central vein. That is also equivalent to that of your third sample from the different site. Okay, so that is the reason why the answer is the fourth option. All right, now, yeah, so this question was the integration of your pathology and as well as the general medicine. So 75-year-old women with type 2 diabetes mellitus and hypertension developed features of the heart failure and expired. That means the patient had death. Postmortem cardiac biopsy slide is given below, right? And what is the diagnosis suggestive of? Dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, 𝗏𝐶 cardiomyopathy, right? Now, so the answer, first of all, you take the age of the individual, that is 75-year-old women. Now, you take this hypertrophic cardiomyopathy, usual age of presentation is around in the young individuals, and that too the presentation will be in the form of like an individual had an exertional activity and presented with sudden cardiac death. And usually the young individuals is what the presentation will be in case of hypertrophic cardiomyopathy. But it is not that the hypertrophic cardiomyopathy should not be there in elderly individuals. It can be also, but usual age of presentation will be in the young individuals. Okay, so that is the reason why this option C is like slight question mark. Okay, we will just take keep it aside. Then you take this 𝗏𝐶 cardiomyopathy. So 𝗏𝐶 cardiomyopathy, the very important history is exposure to the stressful activities. So there should be a history of an stress, either the physical or mental stress should be there within the history in case of your 𝗏𝐶 cardiomyopathy, which is not there in your question. So even this is also a slightly question mark. Okay, so it need not be. But if you take the biopsy picture, whatever the changes you are observing here, right, whatever the changes that you are observing in this portion, it is suggestive of the amyloid pattern, right? This is suggestive of the amyloid pattern. Okay, so this particular amyloidosis is the most common cause for the development of the restrictive cardiomyopathy, right? Amyloidosis, the most commonly it will cause restrictive cardiomyopathy. It does not cause any other form of cardiomyopathy. Whereas dilated cardiomyopathy, the most common toxin that will be causing dilated cardiomyopathy will be the alcohol. And your hypertrophic cardiomyopathy, it is actually due to gene mutation, and it's an autosomal dominant type of inheritance, right? And what is that gene mutated is the beta-myosin gene, right? The gene mutated is the beta-myosin gene. So that is about your hypertrophic cardiomyopathy. So the answer in this question is the restrictive cardiomyopathy. All right, now we'll move on to the next question. That is, the 45-year-old woman presents with bilateral symmetrical tender joints of hands and wrist. She complains of early morning stiffness of more than 1 hour apart. On examination, no erythema or redness was found. What could be the diagnosis? The options are osteoarthritis, psoriatic arthritis, gout, and as well as rheumatoid arthritis. Okay, now the early morning stiffness that is there in more than 1 hour. You take in osteoarthritis also, there can be early morning stiffness, but in osteoarthritis it is less than 1 hour, right? It is less than 1 hour. Okay, whereas in psoriatic arthritis, the description should tell you the classical involvement of the distal interphalangeal joint, but here the joints which are involved is the joints of the hands and as well as wrist. So there is no specific mention about the DIP involvement, distal interphalangeal joint. So psoriatic arthritis also, like, we will keep it aside. Then you take your gouty arthritis. So gouty arthritis, the joint which is most commonly affected, that will be your first metatarsophalangeal joint, right? The joint which is most commonly affected is first metatarsophalangeal joint. Okay, now you take the rheumatoid arthritis. Rheumatoid arthritis is that the answer is rheumatoid arthritis. So in case of rheumatoid arthritis, it is bilaterally symmetrical involvement. So you have bilateral symmetrical involvement and you have tender joints of the hands and as well as wrist. That is what is the classical picture in patients with rheumatoid arthritis. And even the stiffness, right? Even the stiffness will be there for more than 1 hour, right? Even the stiffness also will be there for more than 1 hour. So this is about the correct answer, that is rheumatoid arthritis. All other options can be easily ruled out here in this question. Very simple and easy question. Now, we'll move on to the next question. A 26-year-old female presents with palpitations, weight loss, tremors, sweating, diarrhea. What is the next test that will help in establishing the diagnosis in this patient? Okay, so this is actually the protocol or the algorithm which is given in Harrison very clearly. First of all, what are all these symptoms suggestive of? The palpitations, weight loss, tremors, sweating, and as well as your diarrhea. So all these clinical features, they are suggestive of your hyperthyroidism. Right, they are suggestive of hyperthyroidism. And options, if you take thyroid stimulating hormone, TPO antibody, total T3, and as well as ultrasound of the neck. So your TPO antibody, it can be easily ruled out because this is the antibody that you get in case of the Hashimoto's, right? That you will have in case of the Hashimoto's. Okay, so in case of the Hashimoto's, the antibody is anti-TPO and it is your hypothyroidism. It is not hyperthyroidism. All right, then in the evaluation of the thyroid, what is that we need to check first? We need to check first the TSH and as well as T4, and that too, it should be free T4 that has to be tested for. We don't check the T3 because T3 is formed from T4 upon peripheral deiodinization. So if you see this, yes, this is the table or this is the algorithm which is given in Harrison. So what is the first thing that you will check for? You need to measure the TSH and as well as unbound T4, which is nothing but the free T4. Okay, it is not your T3 at all. Then what about the ultrasound neck? That is not the best investigation which will help in diagnosis of whether it is your hyperthyroidism or hypothyroidism. See, ultrasound neck, it will show you if there is any presence of goiter, that there is a goiter. But this particular goiter, it can be hyperthyroidism, it can be euthyroidism, and it can be even hypothyroidism also. So that is the reason why even your third option is also not the correct answer. So the correct answer in this is the TSH. All right. Now we'll move on to the next question, which was asked on the GAT. Right. So a 42-year-old female with complaints of recurrent episodes of abdominal pain and cramps. Endoscopy is done and diagnosed as the ulcerative colitis. She currently has 3 to 4 episodes of the bloody stools per day. Appropriate initial treatment will be, the options are the budesonide, then sulfasalazine, azathioprine, and as well as bezlotoxumab. Okay, it's a direct question actually, so there is no much explanation. For ulcerative colitis, the treatment that we give is your sulfasalazine. Okay, there is no other alternative again here, right? Now we'll move on to the next question. So this is always a stock question. Hepatitis B serology, always it's a stock question. Many times it has been asked. So workup of a 25-year-old hotel workers shows that following profile. That is, anti-HBsAg is negative, surface antigen negative, envelope antigen negative, anti-HBe that is negative, then only total anti-HBc is positive. What's the diagnosis? Now the options are chronic hepatitis B, inactive carrier, then hepatitis B in the remote past, and fourth option is window period or the gap period. So you take in case of the chronic hepatitis B. In case of chronic hepatitis B, the surface antigen will definitely be positive. So HBsAg will be positive, and then the other important profile that will be positive is the antibody, that is IgG antibody to your core antigen, right? So IgG anti-HBc. Then you take this inactive carrier. So in case of the inactive carriers, is a carrier, so definitely the HBsAg right, the 𝐻BsAg will be positive. Then followed by that, the window period or the gap period. So in case of window period or gap period, the antibody that will be positive is IgM to HBC, right, IgM to HBC. So window period or gap period, it is IgM antibody that is to the HBC. So that is about your option D. Then what is the correct answer here? That is the hepatitis B in the remote past. That is the correct statement. So in case of the hepatitis B in the remote past, the total anti-HBC will be positive, which is nothing but again, it is IgG anti-HBC. Alright, so the answer is C in this particular question. Now anyways, let me just show you the table which has been given in the Harrison. Okay, so this is the table which has been given in the Harrison. So the first 4 conditions, the surface antigen is positive. What are those? Acute hepatitis B, chronic hepatitis B, late acute or chronic hepatitis B, low infectivity, then envelope antigen negative hepatitis B, and as well as surface antigen of one type and heterotypic anti-HBs. So the first 3 surface antigen is positive. So among the options which has been given to you, your chronic hepatitis B is completely ruled out. The first option was chronic hepatitis B, where definitely there should be presence of surface antigen. But in the question which has been given, surface antigen is negative, so that will rule out your chronic hepatitis B, right? Then you take the next 4, your surface antigen is negative. So what are all those? That is the acute hepatitis B and as well as in the window period. But in case of window period, right, actually window period, the surface antigen will be negative. But if you observe, right, these patients will have IgM anti-HBC. That was our 4th option, right? Then you take the low level hepatitis B carrier or hepatitis B in the remote past. So in this patient, your IgG will be positive and your anti-HB plus or minus. It may be positive, it may be negative. So that IgG which is being positive, that is nothing but your total anti-HBC. That is nothing but your total anti-HBC. So that was the correct answer. And recovery from the hepatitis B. In recovery from hepatitis B, you have anti-HBsAg positive, which was negative in the question which has been given to you, right? And yeah, the individual is vaccinated or the immunized. Vaccinated or immunized, it will be anti-HBsAg positive. So the answer in our question is, that is hepatitis B in the remote past, where only IgG will be positive, which is nothing but your total anti-HBC, right? So the answer in this question is your hepatitis B in the remote past. All right. Now we'll move on to the next question. So the next question was about diabetic ketoacidosis, right? So the question is as follows. The child brought to the emergency department in unconscious state with severe vomiting and as well as abdominal pain episodes. The heart rate is 100 per minute and blood pressure of the individual is 100 by 60 millimeters of mercury. Workup showed the pH of 7.2, the blood glucose 300 milligrams per deciliter, ketone 3 plus. What would be the best management? The options are infusion 0.05 or like 0.1 units per kg per hour after 1 hour of IV fluid infusion. That is first option. Second option, 0.1 unit per kg insulin stat followed by infusion of 0.05 unit or 0.1 unit per kg per hour dose insulin and IV fluids. Third option, 0.1 unit per kg insulin subcutaneous stat followed by that IV fluids. IV fluids followed by subcutaneous insulin. See, what is the standard treatment in patients with your diabetic ketoacidosis is, in patients with diabetic ketoacidosis, always the first line management will be the IV fluids. Okay, first line management will be IV fluids. After the IV fluids, because this IV fluids will correct the dehydration, IV fluids will correct the vascular collapse in these individuals. Now, after 1 hour after supplementing the IV fluids, then you need to start with the infusion of insulin. Right, infusion of insulin. So the correct answer is the infusion of 0.05 to 0.1 units per kg per hour dose insulin after 1 hour of the IV fluids. So the correct answer here is A. Now you take the second option. Why it is incorrect? Because see, first they were giving insulin followed by that IV fluids. That is incorrect. You should not do that. And second option, third option, subcutaneous stat followed by that the IV fluids. No, always IV fluids first. Then IV fluids followed by subcutaneous insulin. No, we don't give subcutaneous insulin in case of your diabetic ketoacidosis. In diabetic ketoacidosis, what we give is the intravenous infusion is what we give in patients with the diabetic ketoacidosis. Okay, and followed by that you need to monitor the potassium, you need to treat the precipitating factor. Mostly it is infection, for which you need to give antibiotics, and then you also need to monitor the pH and then give bicarbonate if the pH of the individual is less than 7, or if the bicarbonate is less than 10, we give even bicarbonate as well. Okay, so this is about the management of your diabetic ketoacidosis. All right, now we'll move on to the next question. Now, a known rheumatoid arthritis patient presented to the emergency department with hypotension. She was on medication for rheumatoid arthritis treatment but abruptly stopped medication, and the heart rate of the individual is 110 beats per minute, blood pressure of the individual is 80/40, blood sugar is 50 milligrams per deciliter, sodium 130, potassium 6. What would be the appropriate management in this patient? The options are the fast IV fluids, hydrocortisone, dopamine infusion, and as well as the sodium bicarbonate. So the patient was on the medication for rheumatoid arthritis and abruptly stopped the medication. So we don't know actually what medication was there in the regimen, was not known. But usually the steroids, they're one important part of the treatment, mainly if the individual is in acute phase of rheumatoid arthritis and stopped abruptly. So when these patients who are on steroids, when they stop abruptly, right, what they can develop, these patients, they develop sudden onset acute, right, sudden onset acute adrenal insufficiency, right, acute adrenal insufficiency. Because when the patient is on long-term steroids, what will happen to your ACTH? The ACTH is in a suppressed state. When ACTH is in a suppressed state in a patient with long-term steroids, when ACTH is under the suppressed state, even the adrenal gland will not be in a functional status when the patient is taking steroids for long-term. And when the patient has stopped the steroids suddenly, then the adrenal gland which is in the inactive state will not be able to generate or will not be able to produce the steroid immediately, and thereby these patients will develop acute adrenal insufficiency. And whatever the features which has been given to you, that is your hypotension, your hyponatremia, your hypoglycemia, then followed by that the hyperkalemia. So all these points, they're all suggestive of the acute adrenal insufficiency, where there is decrease in your steroids, and where there is decrease in the aldosterone levels, right? So what is the drug that has to be given in these individuals? That is hydrocortisone. The drug of choice in case of acute adrenal insufficiency will be intravenous hydrocortisone. So this particular hydrocortisone, why is that is being preferred? Why not your fast IV fluids? Why not dopamine? Why not sodium bicarbonate? Because this hydrocortisone, it has the dual activity, right? It has the steroid activity, right? And along with the steroid activity, it also has the mineralocorticoid activity, and that is the reason why your hydrocortisone is considered as the drug of choice here, right? So this is a question of acute adrenal insufficiency. We'll move on to the next question. Right, a 30-year-old farmer from Tamil Nadu presented with fever, myalgia, headache, and cough. During the physical examination, a characteristic black eschar is seen over the chest, right? And lung auscultation showed extensive bilateral rales, and the blood investigation showed positive IgM for scrub typhus. What would be the appropriate treatment for this patient? See, for the scrub typhus, what the textbook gives, either you take Harrison or you take CMDT, what the textbook gives is the IV doxycycline, right, intravenous doxycycline. But according to your WHO guidelines, now this particular patient, lung auscultation, there is also extensive bilateral rales. So according to the WHO guidelines, what it says is, along with doxycycline, right, along with the doxycycline, the other drug that need to be added is the azithromycin. Okay, but if you go according to the textbook, that is to the Harrison or your CMDT, then the answer will be your doxycycline, right? And if you go according to your WHO guidelines, that will be doxycycline with azithromycin. Okay, so right, this is a bit of the controversial question, like what is there in the examiner's mind, we don't know. But usually if the AIIMS is following like the Harrison strictly, then the answer is your doxycycline. All right, now moving on to the next question, that is 26-year-old female presented with the bleeding disorders. She gave history of the father and sister having same bleeding issues. Which is the most likely disorder in this patient? So von Willebrand, then hemophilia A, then Christmas disease, then factor 10 deficiency. So among, see, the father and as well as sister also having same bleeding disorder. That means what? It is an autosomal dominant type of disorder. So which is that autosomal dominant disorder? It is your von Willebrand disease, your your hemophilia and as well as Christmas, right? That will be your X-linked, and your factor 10 deficiency, it is your rare form and it is an autosomal recessive pattern. So the clinical pattern which has been given is of autosomal dominant variant. So in case of autosomal dominant, what is the option here? That is your von Willebrand disease. So the answer is A, first option. All right, now we'll move on to the next question. 30-year-old patient presented with high-grade fever for past 1 week. On examination, neck stiffness and Kernig sign was positive. CSF analysis showed lymphocytosis, protein is 80 milligrams per deciliter, glucose 40 milligrams per deciliter, but that is CSF glucose is 40 milligrams per deciliter, and RBS, that is plasma glucose, is 140. What is your diagnosis? First option, these patients, they are having lymphocytosis. Okay, you see the options: tubercular meningitis, Coxsackie meningitis, bacterial meningitis, and HSV1 encephalitis. So lymphocytosis you see in case of tubercular, or you see in case of viral infections. So your bacterial infections is completely ruled out, or bacterial meningitis is ruled out. Why? Because in bacterial meningitis, it is your neutrophilic predominant. And now in this patient, if you see the glucose levels, the CSF glucose is reduced. How much should be the CSF glucose? It should be 2/3 of the plasma glucose. That should be the CSF glucose. And you take the plasma glucose, it is 140, right? So your CSF glucose, it is less than 2/3 of the plasma glucose. So the glucose is the CSF glucose is definitely reduced in this particular patient, right? So now among the options given, your Coxsackie meningitis and as well as HSV encephalitis, that is in case of the viral infections, the CSF glucose will remain normal, right? The CSF glucose will remain normal. Then what is the correct answer here? That is the tubercular meningitis. In tubercular meningitis, you have lymphocytic predominant. There will be lymphocytosis. Your CSF glucose will be reduced. And even if you take the proteins are also elevated. That is 80 milligrams per deciliter. So this is a classical picture of the tubercular meningitis. And in patients with meningitis, you have all the features suggestive of meningitis. That is your high-grade fever, neck stiffness, and as well as the Kernig sign. So the answer in this question is the tubercular meningitis. Okay, next question. Okay, so 30-year-old HIV positive man presents with neck rigidity and as well as the papilledema. So papilledema says that the individual is having raised intracranial pressure. CSF sample showed capsulated organism positive for India Inc. strain. Which of the following statement is true? The options are: CSF pressure remains normal, delay antiretroviral therapy for 2 to 3 weeks, initiate treatment with liposomal amphotericin B, brain imaging shows changes in more than 80% of patients. Okay, so HIV positive individual, capsulated organism, and positive for the India Inc. Okay, so what is this suggestive of? This is suggestive of cryptococcal meningitis, right? Cryptococcal meningitis. So in case of the cryptococcal meningitis, okay, so meningitis itself says that the CSF pressure is elevated, and not only that, there is papilledema. So CSF pressure remains normal. It is an incorrect statement. Okay, right, the correct answer is here B. Now why not C and D? Let me tell you. Initiate treatment with liposomal amphotericin B. See, in case of your cryptococcal infection in acute, the initiated treatment, it is not just only liposomal amphotericin B. We also need to start 5-fluorocytosine. both have to be given in patients with the cryptococcal meningitis. All right, next. So your C is incorrect. And brain imaging shows changes in more than 80% is wrong statement. See, these patients with cryptococcal meningitis, so what is that characteristic imaging is, you have this characteristic soap bubble appearance. And this particular soap bubble appearance in case of the cryptococcal meningitis, it is present only in case of 50 to 60% of patients, but not more than 80% of individuals. So which of the following is the true statement, right? You delay the antiretroviral therapy for 2 to 3 weeks. Now, what is the purpose? Why you need to start the antiviral therapy after 2 to 3 weeks? Why? Because in any case of the opportunistic infection, your opportunistic infection and as well as antiretroviral therapy should not be started simultaneously. Why? Because of the risk of development of IRIS, that is your immune reconstitution inflammatory syndrome. So in order to avoid the risk of development of IRIS, when both the drugs are started simultaneously, these both should not be started simultaneously. So delay antiretroviral therapy for nearly around 2 to 3 weeks, right? For 2 to 3 weeks, you need to delay. So that means you need to give antifungal drugs first. After 2 to 3 weeks, you need to start the antiretroviral therapy. Okay. So delay antiretroviral therapy for 2 to 3 weeks. That is the correct statement in this question. All right. Now we'll move on to the next one. So, a 40-year-old patient of grade 2 steatohepatitis of the liver presents with right upper quadrant pain, and AST and as well as ALT has been raised with intake of 2 to 3 alcohol drinks daily and has a BMI of 29. What will be the most appropriate advice for this particular patient? Lifestyle modification plus regular exercise, lifestyle modification plus vitamin E and 𝗑𝐲𝐸𝐴𝐳 acid, lifestyle modification plus pioglitazone, and then lifestyle modification only. So now the patient is consuming 2 to 3 alcohol drinks daily. So, and even your enzymes, they are elevated, and the patient is also having right upper quadrant pain. So this is suggestive of your hepatitis. Why? Because enzymes are elevated, and even the patient is also having right upper quadrant pain. So this is like classical presentation of your hepatitis. Now this hepatitis, it is not non-alcoholic steatohepatitis, because the history says that the patient is consuming almost 2 to 3 alcohol drinks daily. So it is not your non-alcoholic steatohepatitis. You take your option B and option C. Your option B and as well as option C, both of them, they are mainly for the treatment of NASH, that is non-alcoholic steatohepatitis, which is very common in obese individuals, which is very common in type 2 diabetics, which is very common in individuals with insulin resistance, which is very common in patients with the metabolic syndrome, right? But not in case of your alcoholics. The word itself is telling you non-alcoholic steatohepatitis. So in non-alcoholic steatohepatitis, the treatment is lifestyle modification, vitamin E, 𝗑𝐲𝐸𝐴𝐳 acid, and as well as the pioglitazone. The pioglitazone, it is an insulin sensitizer there, okay? Right. But because the individual is consuming alcohol, so the diagnosis in this individual will be alcoholic hepatitis. So this will be alcoholic hepatitis. So the answer in this question is A, that is lifestyle modification plus regular exercise has to be done. So that is A, right? Now moving on to the next question. Comment on the lung disease. The options are bronchiectasis, chest neuromuscular disorder, interstitial lung disease, and then the sarcoidosis. So if you see the pulmonary function test which has been given, so this is the normal thing which has been given, and this is the lung disease. Okay, so and they have also mentioned the values. What were the values? In the normal individual, the FEV1 by FVC was 83%, right? In the diseased lung, the FEV1 by FVC is 50%. That is what is the values that has been given mentioned in the question. So now your FEV1 by FVC is reduced. So FEV1 by FVC is reduced in patients with the obstructive lung diseases. So what are all the examples of your obstructive lung diseases? That will be your asthma, then bronchitis, right? Then bronchiectasis, okay? Then COPD, and next cystic fibrosis. So these are the examples of the obstructive lung diseases. So among the options which has been given to you, because the pattern is suggestive of your obstructive lung disease, that is the reason why it is your bronchiectasis as the answer. Whereas you take in all these three conditions, the chest neuromuscular disorder, then interstitial lung disease, and as well as in case of sarcoidosis. So in these three conditions, please remember it is restrictive lung disease, right? It is restrictive lung disease. So in case of the sarcoidosis, right, in case of sarcoidosis and as well as the interstitial lung disease, it is parenchymal type of interstitial lung disease, right? It is parenchymal type of the interstitial lung disease. Whereas in case of the chest neuromuscular disease, it is the extraparenchymal type of, right, this will be extraparenchymal type of the lung diseases. Okay, that is chest neuromuscular disease. What will be the chest neuromuscular disease? Like you take Guillain-Barré syndrome, motor neuron disease, myasthenia gravis, phrenic nerve palsy, diaphragmatic palsy, cervical spine injury. They come under your neuromuscular disorders. All right. So in all of them, the restrictive lung diseases, what will be your FEV1 by FVC? So FEV1 by FVC in restrictive lung diseases, it will be more than or equal to 70%. Okay, but here it is 50%. That is the reason why the answer is bronchiectasis. All right. Now we'll move on to the next question. 70-year-old diabetic man presents after a fall. He is having high fever, cough, and breathing difficulty and appears confused. Chest X-ray shows lobar consolidation. Labs show elevated blood urea nitrogen and as well as creatinine. Which is the most appropriate management in this patient? So, high fever, cough, breathing difficulty, and appears confused. Chest X-ray suggestive of your consolidation. So this is a classical picture in patients with the pneumonia, right? This is a classical picture in patients with the pneumonia. So in pneumonia, you need to calculate this 𝐒𝐫65 score. Okay, so the patient is confused. So confusion is there. Give a score of 1. So there is raised blood urea nitrogen and as well as the creatinine. U stands for urea. Give a score of 1. And R is your respiratory rate. The individual is having breathing difficulty. Definitely your respiratory rate might have been elevated, right? 1. Okay, again this is a question mark because they did not mention the respiratory rate. We are just assuming. We will just keep it as a question mark. Then your 65. Age of the individual more than 65. So if you take here, age of the individual is 70 years. So definitely 1. So even if you take these, like the score will be 3. So when the score of the individual is 3, definitely they have to be admitted in the hospital and that too within the ICU, and they have to be given high-end antibiotics. And that too, when comorbidities are there, the preferred antibiotic, see this patient is a diabetic. When the comorbidities are there, the preferred antibiotic will be your levofloxacin, right? That will be your levofloxacin. Or the other alternative option is, that is your amoxicillin plus clavulanic acid. Along with amoxicillin plus clavulanic acid, you need to add azithromycin also. Both of these should be combined, right? But if it is in the options which has been given to you, amoxicillin clavulanic acid was given separately and azithromycin was given separately. So only amoxicillin plus clavulanic acid you can give when the 𝐒𝐫 score is just 2. But here 𝐒𝐫 score is 3 or more than 3. So they require the combination of the antibiotic, or if the comorbidity is there, you need to give levofloxacin. Okay, so the answer in this question is levofloxacin without any doubt. Now the last question. A patient with stroke presented with the inability to identify the object but can identify the color, texture, shape of the objects. Which of the following lobes is involved in this patient? So it's a direct question. The answer is the temporal lobe. Okay, so these are the questions which was being asked in the November 2023 INICET General Medicine. So with this, I'll wind up this session. Thank you very much.